Welcome to The Explainer. I am absolutely thrilled to have you here today because we're jumping right into a topic where human ingenuity literally meets life or death stakes. We're talking about the surgical management of bradycardia and the evolution of cardiac pacing. The human heart is, at its core, this intricate, highly sensitive electrical machine. And when the wiring of that machine fails, well, the results are immediate, they are terrifying, and historically, they were almost always fatal. But today, we're going to explore exactly how medical science learned to hack that electrical system, save countless lives, and fundamentally change the entire landscape of cardiac surgery. Okay, let's dive right into this, because to truly appreciate where we are today with medical management, you kind of have to understand the horrifying reality of where we started. I mean, imagine being a patient in the 1950s with complete heart block. Your heart simply will not beat on its own. The only thing keeping you alive is an external pacemaker, which back then was this massive, clunky machine delivering powerful electric shocks through bare electrodes resting right on your skin. Every single heartbeat came with an agonizing skeletal muscle contraction and burning skin excoriations. As our source material notes, patients developed sheer terror when the surgeon approached. Why? Because the surgeon actually had to briefly turn off this agonizing machine just to see if the patient's own heart would restart. And if it didn't, the patient would instantly suffer an Adam Stokes episode, basically passing out from lack of oxygen before the machine was frantically turned back on. It was a brutal, desperate measure for sure. So here is our roadmap for today. We'll quickly cover 1. Understanding abnormal bradycardia. 2. The evolution of pacing. 3. Medical and surgical management. 4. Decoding pacemaker modes. 5. Guidelines for intervention. And finally, 6. Outcomes and complications. Let's get to it. Starting with Section 1, Understanding Abnormal Bradycardia. Let's clearly define the biological failure we are actually trying to solve here. Abnormal bradycardia is not just a slow heartbeat. It's a critical, systemic failure of cardiac output. Your brain is exquisitely sensitive to hypoxia, right? So when the heart rate drops too low, the elasticity of the aorta simply cannot maintain enough blood flow during that incredibly long pause between beats. The result is syncope, classically known as an Adam Stokes episode. But honestly, it gets even more dangerous than just fainting. Notice the mention of life-threatening arrhythmias up there? The longer the interval between ventricular depolarizations, the more the heart's electrical reset phase, the QT interval, prolongs. This makes the patient highly vulnerable to fatal, chaotic rhythms like torsades de pointes or even prolonged ventricular asystole. In short, the heart just stops completely. Moving on to Section 2, the evolution of pacing. So how exactly did we go from agonizing external shocks to these tiny, invisible computers? Well, the timeline of innovation here is just breathtaking. We go from Robert Adams first describing the syndrome way back in 1827 to Paul Zoll's brutal but genuinely life-saving external pacemakers in 1952. But the real game changers, those came with the invention of the transistor. In 1959, Elmquist and Senning placed the very first totally implantable pacemaker. And then a massive leap forward happened in the 1970s, the lithium battery. This was absolutely crucial. Before lithium, pacemaker batteries released hydrogen gas, which meant the devices couldn't be completely sealed. Lithium cells were not only vastly more reliable, but they didn't off-gas at all, allowing engineers to hermetically seal the entire device. That single innovation paved the way for the microprocessors and the incredible multi-programmable devices we rely on for patient management today. Which brings us to Section 3, Medical and Surgical Management. Let's look at how surgeons physically intervene to fix this electrical failure today. Right now, the standard of care is the transvenous electrode insertion. It's a beautifully elegant, minimally invasive procedure, usually just done under local anesthesia. The surgeon makes a small incision below the collarbone to create a subcutaneous pocket for the generator. Then, using a needle, they carefully puncture the subclavian vein. A guide wire is threaded in, followed by a peel-away sheath. Through this tiny tunnel, the pacing electrode is advanced all the way into the right atrium, down through the tricuspid valve, and into the right ventricle. And this is all guided entirely by real-time fluoroscopy. Once they are inside the ventricle, the surgeon carefully withdraws the lead along the septum until they find the absolute perfect spot among the muscular ridges, the trabeculations near the apex. The lead is then actively screwed into the heart muscle. But they aren't done yet. They have to test the pacing threshold, which is the lowest voltage needed to trigger a heartbeat. An optimal threshold is 0.3 volts or less. They also test the sensing threshold to ensure the pacemaker can actually hear the heart's natural beats. It's a procedure demanding incredible precision for proper long-term management. Now, while transvenous insertion is the gold standard, surgeons do sometimes have to pivot to an epicardial thoracotomy, which is an open chest approach. This usually happens if the patient is already having concurrent cardiac surgery, like a valve replacement, and they happen to develop heart block during the operation. The surgeon will just sew the electrodes directly onto the epicardium. But there is one specific anatomical scenario where an open chest is absolutely mandatory. If the patient has a mechanical tricuspid valve prosthesis, you literally cannot pass a transvenous wire through it without either destroying the valve's function or shredding the wire. In those cases, epicardial leads aren't just an option, they are a surgical necessity. Section 4. Decoding pacemaker modes. So, once the hardware is physically installed, how do we program the software? So, the crucial point here is understanding this universal four-letter coding system. Clinicians use this alphabet soup to instantly communicate exactly how the device is interacting with a patient's unique physiology. The first letter tells you where the spark is actually delivered, the chamber paced. The second letter tells you where the pacemaker is listening, the chamber sensed. The third letter dictates the device's response. Does it inhibit its own spark if it hears a natural beat, or does it trigger one? And the fourth letter indicates if the device is rate adaptive. That means, can it sense physical activity and speed up the heart rate when the patient exercises? Let's see how this plays out in real life with the three most common modes you'll see in medical management. VVI is basically the workhorse. It paces and senses the ventricle and inhibits itself if it detects a natural beat. It's incredibly reliable, it saves battery, but it ignores the atria completely, meaning the patient loses that vital atrial kick that helps fill the ventricles. On the flip side, AAI paces and senses the atrium. This perfectly preserves that atrial kick, but it's really only an option if the patient's AV node is perfectly healthy. And then we have DDD, which is universal pacing. It paces both chambers, senses both chambers, and can either trigger or inhibit. It's amazing because it perfectly mimics a healthy heart, adapting to the patient's needs moment by moment. The trade-off? Well, firing two chambers constantly drains the battery much faster and requires a much more complex surgical implant with two separate leads. Section 5. Guidelines for intervention. With all this amazing technology available, how do doctors actually decide who gets a pacemaker? The guidelines set by the ACC, AHA, and HRS are pretty extensive, but they really boil down to one major theme: symptoms. For acquired AV block, a Class 1 absolute indication is third-degree block accompanied by symptomatic bradycardia. That means the patient is actually fainting or they're in heart failure. For sinus node dysfunction, which you might know as sick sinus syndrome, it's all about documented symptomatic pauses. Interestingly, a patient might have a really slow resting heart rate of, say, 35 beats per minute, but if they feel completely fine and have no symptoms at all, that often falls into a Class 3 category, meaning a pacemaker is actually not indicated. We treat the patient, not just the number on the EKG monitor. Finally, Section 6, Outcomes and Complications. What is the long-term reality of living with one of these devices? And this brilliantly illustrates the impact of surgical management. Take a look at the 15-year survival curve here. Before this technology, a patient suffering Adams-Stokes episodes from complete heart block had a completely dismal 50% chance of surviving just 1 year. But now, 5-year survival jumps to 59%, and even at 10 years, it's hovering near 40%. The device fundamentally alters their natural history, preventing sudden arrhythmic death. It is a massive medical triumph. However, when we break down that 5-year survival by age, a slightly different picture emerges. The reality is that abnormal bradycardia overwhelmingly affects the elderly population. While a patient in their 40s has a great 83% 5-year survival rate, you can see a sharp drop-off as we enter the 80s and 90s, dropping down to about 51%. Advanced age, along with tricky comorbidities like ischemic heart disease and chronic heart failure, are really the primary drivers of late mortality in these patients, rather than the electrical failure itself. Now, of course, no surgery is completely without risk, and part of proper medical management is being honest about the complications. Even with meticulous sterile technique, pocket infections or erosions of the generator through the skin happen in about 0.5 to 2% of cases. When this happens, you can't just give the patient some antibiotics. The entire system usually has to be surgically extracted and fully replaced on the other side of the chest. There's also this fascinating complication known as pacemaker syndrome. This happens in nearly 10% of patients paced in that simple VVI mode we discussed earlier. Because the atrium and ventricle are beating completely out of sync, the atrium sometimes contracts against a closed valve. Blood shoots backward, blood pressure drops, and the patient feels dizzy or faints, which is literally the exact symptom the pacemaker was supposed to fix. The surgical cure for this is upgrading the patient to a dual-chamber DDD system. You also need to notice the hidden danger lurking years after surgery on this graph. Ideally, you want that threshold line to stay low and flat. But look at these massive, totally unpredictable spikes occurring 70 or 100 months post-implant. Over time, fibrotic scar tissue can build up exactly where the wire meets the heart, suddenly increasing the electrical resistance. If the pacemaker isn't programmed to deliver a high enough voltage to overcome this new spike in resistance, the heart won't capture the signal. This loss of pacing can absolutely cause sudden death. This is exactly why patients require lifelong routine medical surveillance to constantly check and adjust these life-saving devices. It's not just a set-it-and-forget-it surgery. We have journeyed from agonizing external shocks to sophisticated, multi-programmable computers implanted right in the chest. But you know what? The evolution hasn't stopped. Our source material points directly to the thrilling frontier of entirely leadless pacemakers. Imagine a device the size of a vitamin, delivered through a catheter, sitting entirely inside the heart itself. No wires to fracture over time, no surgical pocket to get infected. As we look at this rapid acceleration in microtechnology, I want to leave you with this provocative thought. How will these invisible, leadless marvels completely rewrite the surgical management of arrhythmias over the next decade? The pace of innovation is electric, and the future of cardiac surgery is unfolding right before our eyes. Thank you so much for joining me on this explainer, and keep learning.